we're going to be talking about labs because...
And not the dogs.
Not the dogs. Yeah, Emily, how come you don't have a New York accent? You grew up in New York for...
I did.
A while.
Well, I wasn't there as long as Andrea was.
Right. I love Andrea's accent.
I know.
I only have certain words that I still can't get rid of. Dogs, coffee, basket, those. I don't want to get rid of them. I mean, I could if I wanted. Basket.
That's
dog,
boring.
But it's boring.
Labs are an important part of treating metabolic dysfunction, right, Dr. Cooper? Explain, if you would, why labs are so vital.
Labs are really important because they serve as a window into our physiology, and they're the main way that we can look and see what the biologic actions are internally. And so we have other markers that don't require labs, such as blood pressure and body weight, body height, heart rate, oxygen saturation. But looking at the physiologic changes that occur through the lab work is really, really enlightening.
This is Fat Science, a podcast dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better. This podcast is for informational purposes only and is not intended to replace professional medical advice.
I'm Dr. Emily Cooper. I've been treating patients with metabolic issues for over 25 years. I'm on a mission to raise awareness about metabolic dysfunction and why diets don't work.
Hi, I'm Andrea Taylor. I've been fat, very fat, chubby, morbidly obese, and done almost every diet ever invented. They all worked until they didn't. I've known Dr. Cooper forever, but when I became her patient and we learned metabolism was the real problem, wow, everything changed, and I've never been healthier.
And I'm Mark Wright. It's time for Fat Science.
Wait, does this podcast make me look fat?
Welcome to Fat Science. I'm Mark Wright, along with Andrea Taylor and Dr. Emily Cooper. It's great to see you two.
Great.
Hello.
Yeah, hi.
All right, on the show this week, understanding labs as it pertains to treating metabolic dysfunction and metabolic syndrome. So, Dr. Cooper, we're going to break down the labs that I've done, the labs that Andrea has done over the years, and really how you look at the labs as an indicator of where we are in a point in time. One of the reasons that we thought this was important is because when you look at the labs that we've done over the years, more than a decade for Andrea and for me, it shows you how long the process is of treating metabolic dysfunction. It does not happen overnight, and it can't be fixed overnight. So this is going to be a really fun episode. I think, Dr. Cooper, we should probably start, because whenever I talk to people about the podcast, they say, well, what's metabolic syndrome? So from just a basic description, what is metabolic syndrome?
Well, metabolic syndrome is a collection of problems with the metabolic system that manifest as different disease processes. So, for example, prediabetes and diabetes, when it's in conjunction with two other conditions such as high blood pressure or cholesterol problems, especially with elevated triglyceride levels, if those three things are present, that's metabolic syndrome. But it could be other components also that make up the three criteria. That could be fatty liver disease. It could be elevated triglycerides but low HDL cholesterol. It could be full-blown diabetes. Could be elevated insulin levels. So there's a group of conditions that when they're seen together, if there are three together, that constitutes metabolic syndrome. And the reason why we go with that term is really, a lot of it is to get the attention of healthcare providers and patients that they're entering what I call a high-risk metabolic dysfunction situation that really elevates their risk for problems such as acute cardiovascular events, heart attacks and strokes, diabetes, bad fatty liver disease, things that really carry a stronger risk than just if you had one of those elements isolated.
So let's talk about the process of doing the labs. Andrea, you and I have done this for many years. Explain to people listening who may not be familiar with the process what happens when we do our labs, when we give blood.
Well, we have a lot of different lab tests that we do, and we do them about every 3 to 4 months so that Dr. Cooper can track the medications that we take and track how we're doing and how our progress is going. Because The other thing that's really interesting about labs is you can't lie about them, or at least we don't know how to lie about them because we're not scientists and we're not lab technicians.
Right.
So we don't know how to make anything lie. I mean, we don't know how to do that. At least I don't know how to do that.
Yeah.
And you go to either a facility or to a doctor's office or something, and they poke you. And we do a test that I call it the eating test. Dr. Cooper likes us to eat a breakfast so that she can get a fasting level, and then 30, 60, 90, or sometimes it's a 1 hour, 2 hour, 3 hour, depending on what it is, so that she can see what's happening when you eat and how your body is reacting to food. Now, a lot of labs, this is an interesting thing, a lot of labs like to test your glucose and insulin levels with some sort of goo. It's some sort of goo that they make you eat. And they do it a lot of times for pregnant ladies, because you see a lot of pregnant ladies in the waiting room. But as Dr. Cooper said, I really don't care how your body reacts to goo. I want to see how your body reacts to food. And because you're not eating goo all the time.
Unless you're like a triathlete or something.
Yeah, well, but I think it's like sugar syrup or something. It's like syrup or something. It looked gross. So she wants us to bring a really kind of healthy, hearty breakfast to see how our body is reacting as the food goes through our system.
Yeah, so we fast, not having eaten from the day before. They do a blood draw. Then we have a meal, a balanced meal that includes starches, fats, and proteins. And then, at least in my case, they draw,
and
again,
coffee in my case, too.
30, 60, 90. I always have coffee, too, as well. So, Dr. Cooper, the labs, as you do them, what are some of the things that you're looking at? And then let's break down the case of where Andrea was in the beginning and where I was.
Yeah, this is going to be
Light
not
years
embarrassing,
difference.
but for us, it's
Oh
not
my
embarrassing
gosh.
because it's not embarrassing to me anymore because, like, my life is an open book.
We've signed the HIPAA agreement.
We signed a HIPAA agreement, whatever. I honestly don't care. I'm sort of
I don't either.
because I'm happy that I'm healthy now. And I mean, I wasn't really healthy then, and I'm happy that I got healthy. So I'm happy to share with everybody what was wrong and now what's not wrong. And I feel so much better now. I mean, I'm not just lighter, I'm healthier and happier too.
Absolutely. So we've done a whole episode on blood work, but Dr. Cooper, as it relates to Andrea and me, like what are some of the things that you look
What
at?
were our problems?
Our problems. Yeah.
What were our problems?
So you recognized right away with me, you're like, I think you may have metabolic syndrome. And I was like, what's that?
Yeah.
So take us from there. When you start looking at labs in the very beginning, what are you looking for?
Well, that's the thing, and that's why it's important to get those fasting labs done. And they don't have to be over, extreme fast, just the overnight fast is adequate. And then that eating test, it's called a mixed meal tolerance test, MMTT. And that's different than, as Andrea said, drinking the glucose drink.
Yeah, don't do that.
Because the glucose drink, it's fine for certain things, but not for what's really going on day to day and to understand the physiology of how it works on a day-to-day basis. Glucose interacts with our body differently than food does. So we prefer to see how the body interacts with food. And what we're mainly looking at is the baseline levels and then how that changes when eating. And there's a transitional phase from going from not eating to eating that is kind of a unique part of the metabolism path, and it's an area where things can become unstable. And so that's why we check the levels of glucose and insulin as quickly as 30 minutes after eating. Even though you didn't digest the food yet, that's a good time to look at that transitional phase. And then we continue on at regular intervals.
So things like insulin, is that something you can measure in that first one?
Yes, we measure the insulin at all of those time points. So the fasting level of insulin and glucose, and it's important to do them together because there's actually relationships of how it should be, how much insulin relative to the glucose in the fasting state versus after eating. There's calculations that are done to see if you're within a normal window or if there's some issues where you're over or under that. So we look at that insulin and the glucose fasting and after eating. at 30-minute intervals. Usually in our clinic, for most of our patients, we only go to 90 minutes, but there are some cases where we would go longer, and there's some cases where we start testing at 15 minutes too, because of a lot of dysfunction that we might see early. But in any case, in addition to that, we're looking at some of the basic disease risk factors that we've talked about before, which have to do with your cholesterol panel, your LDL cholesterol particles, your triglycerides, your HDL, your fatty liver markers, and keeping in mind that even though the blood test looks okay, there could still be issues when it comes to fatty liver. But looking at all your hormone levels and blood counts and nutrient levels, there's just so many things we look at. And we actually do look at a lot of metabolic markers, which the list has narrowed over the years because of insurance, like just compensation, just dropping and dropping really from these tests. So what we used to be able to measure that was very helpful, the list has narrowed, and now if patients really want to see some of those results, there's a higher out-of-pocket cost. So that may vary depending, but those additional tests could be things like GLP-1 levels, for example, that we talk about. We're taking GLP-1 hormones, but do we measure your own GLP-1? Not usually. And it's a very hard test to measure accurately because it's very sophisticated, has to be sent to a very good reference lab in the country that uses the proper preservatives and things like that, or you will just not get the accurate results. There's other markers we can measure, GIP. We can measure catecholamine levels, glucagon levels. We can measure, of course, leptin and ghrelin and neuropeptide Y, a Goody-related peptide. These are all things that we discussed in our lab episode, but this may or may not be on our panels depending on the out-of-pocket costs and things like that, and the case of whether it's important or not to measure all of those. But you get a very good picture. And because both of you started a long time ago, that was when a lot of these tests were covered. So we actually got a very comprehensive picture way back in like 2012. I was just looking at my notes, and Mark, yours was also 2012 when you started.
Yeah.
So Andrea started earlier than you. But even back then, we were able to obtain levels of most of those elements that we're talking about. So we got a very clear picture of that metabolic system and what level of famine signaling was there, how secure were the signals that said we're not in a famine, what were the hormones doing, what were the health parameters doing. And that's where early on, I remember telling Andrea, you had the very high level of famine signal called neuropeptide Y.
Right.
And it was about almost 300 points above the top of the normal range.
Wow.
And that's
And why was that?
because of old diets, probably. That was the same level that you see in patients, because I had previously worked a lot with patients with anorexia nervosa, and their levels were the same, basically, when they were literally starving. So that was really interesting when we saw that, because that was early on when we were first able to test, some of those neurotransmitters. And the other thing that you had, Andrea, your leptin, which was the body fat signal, was only 40% of what it should have been based on your actual weight. So your body fat was trying to hide, to try to preserve itself. So that was showing that weight defense from all the old diets. And at the same time, Andrea had diabetes markers, because your A1C was actually, like, I looked it up, 6.5, and your fasting glucose level, or your A1C was like between 6.5 and 6.6. Your fasting glucose was about 112, and you showed insulin resistance and other things.
So, Andrea, what's your reaction when you hear all those
I
old numbers?
I forgot how bad it was. I do remember thinking, oh my God, my body thinks that I'm really skinny and I'm really fat. Oh, maybe this was the problem all along. There's a confusion. Oh my God. But yeah, there was a major, major confusion. I mean, believe me, I was not anorexic and I was not thin. I was about, probably then, I think I was about 150, 160 pounds heavier than I am now. We can tell you honestly, I was not, the body fat was not hiding. It was right out there for everyone to see.
And Andrea, you're not tall. How tall are
No.
you?
Well, I was a little taller then. Now because I shrunk,
Oh, okay.
but I am now 5'2". So that was a lot of roly-poly there.
And Dr. Cooper, when we look back at Andrea's history of being on so many diets over the years,
Yeah,
every time, how many?
we counted like around 36 or 37, but
Wow.
and these were not just like, oh, let me lose 5-10 pounds. These were like, let me lose 75 to 100 pounds, like
Wow.
each time, maybe 60, 75 pounds each time, major weight.
So those diets were like, hey, it's working, yay. And then all of a sudden, boom, there's a
Oh
rebound.
God, here it comes again.
What
Yeah.
does that do, Dr. Cooper, when people go through a cycle, not just one diet, but let's, say, a bunch of diets over the years? Is that why those levels were so profound?
Yes, it really puts people into the biologic weight defense where their hormones of security damp down and the famine signals ramp up. And so that helps slow the metabolism down and increase the body weight. But also, it can lead to that fatty liver disease. And because of the weight cycling up and down, when you gain the weight back, it often ends up in the visceral area around the organs because that's like a post diet effect. And for a lot of people, and so Andrea, that was the other thing, your liver
Right, I
fat
had that.
markers were really high initially, and not to be like offensive or anything.
Right.
But remember, we tried to get a heart scan because
Yeah.
your LDL particles were really high
Really bad.
risk. But remember, they couldn't do the scan
Yeah.
because of your body size.
Yeah.
And it wasn't like a weight thing. It was just that the images were not reliable because you were so small, but carrying so much extra weight. And
Yeah.
so it just was obscuring the images too much with that superficial
Right.
fat layers. So they recommended waiting until we could get the weight level down to try to get the heart scan.
Yep.
Wow. So, Dr. Cooper, as you looked at Andrea's numbers in the very beginning, how do you prioritize what to treat first? And explain again the definition of like prediabetes and diabetes. I can never remember what that is.
Well, normal glucose without prediabetes or diabetes would be below 100 fasting. And the HbA1c, which is the 3-month average marker, that should be below 5.6. So 5.5 or under. Then prediabetes, the fasting glucose would be 100 to 125. And diabetes is 126 and higher. And the HbA1c marker, prediabetes, is 5.7 to 6.4, and diabetes is 6.5 and higher. So those are the cutoffs. And so Andrea originally was in the diabetes range, but in what would be called controlled diabetes, because uncontrolled diabetes would be if the A1C goes above 7. And so that's just saying that your average glucose is really getting higher. So it wasn't, most doctors might look at it and say, oh, it's pretty good. Your diabetes is pretty good. But we look at it more from a standpoint, to be honest, people with a high body weight that have prediabetes or diabetes often have a much greater chance of reversing the diabetes than someone who's at a normal weight with prediabetes or diabetes. So I see it as an opportunity. It's like, oh, this is a good combination. We've got diabetes, but we also have high weight. So that means the diabetes should be reversible. And it's not reversible just because of losing weight by any means. It's reversible because if you can improve your metabolic function to kick in the body's awareness that there's this extra body fat there, and the body willingly starts to burn that because it thinks that's wrong. Not intentional weight loss, but almost like an unintentional, like the person's not trying to do it. It's their metabolic changes that are improving the system and enabling them to actually access the stored body fat reserves. That process of burning those stored body fat reserves further reassures the body that it's not starving, and it corrects the sense of famine, and it undoes a lot of the diet damage that was there. That's provided that is happening without being on a diet, basically.
If you could speak, Dr. Cooper, to the rationale behind having labs every 3 to 4 months, because my sort of observation is that this is an extremely fluid and dynamic system, this thing called our metabolic loop. And it seems like it is so variable and so many things affect it that Is that why you need to take 3-4 times a year extensive blood labs so you know what's changing, what's not, what's stubborn, what to attack? Is that the rationale?
I mean, and some patients will fall outside of that criteria, but we do like that normal rhythm just for our own patients usually. And the main reason is they're on different treatments and things. And so we have to make sure, first of all, it's safe. And usually they're all safe, but every once in a while, you never know if someone's having some kind of a reaction to something. But then also whether it's working, because you don't want to just leave someone on something forever that's not working either, and whether something needs to be changed or adjusted, or if it's too strong, we ready to taper something. So these are all points where we can assess, are things improving? Are they getting worse in any areas? Is it showing, are there signs that we can taper a medication? We're not as reliant. We don't need that one anymore. So it's really beneficial. And then also it's great to have these touch points with patients because we look at the nutritional status of our patients really closely and can tell if our patients are not eating enough food, then we have to reinforce that, maybe have them get hooked up again with our dietitian to make sure that they know how to eat in that ordered, regular, consistent way. And if there's still any diet mentality, trying to continue to get rid of that. And so with our patients, we'd like to have that kind of contact and to look at the health, to look at the reaction to treatment, to see if we need to adjust anything. But we do have some long-term patients that are pretty much on cruise control too, that we don't see nearly as often as that.
So, Andrea, how are you today?
My A1C is, it's like 5.3, 5.4, I guess. No fatty liver. What was my fasting? I
It's
don't remember.
normal,
What,
like
it was
80 something.
like 80 something.
Your cholesterol's really good.
Yeah. All those things.
Your blood pressure is
Blood
really
pressure
good.
is really good, is normal or, regular. All those things. I mean, all those things are really good.
Yes.
I mean, it's obviously it's more than a decade later, and it's still a work in progress. I mean, that's also the thing I want to stress. It's not over.
Well, the
It's
thing
not like, oh, I'm done.
Well, and I don't think people should look at it that way, even because if you think about it, this
Yeah.
is your genetics, like you
I
said,
I don't
Andrea.
have great genetics.
And you were saying before when you're trying to help me explain this to people, it's just like the deck or cards
Yeah.
you're dealt or whatever,
Yeah,
you
not
know.
so good.
And so it's in your genes, and there are risks that you know about, and that's part of your makeup. So
Right.
we shouldn't be looking at this as like, oh, I'm doing this thing and then it's going to fix the thing and we're done.
Right.
There's some endpoint. This is healthcare. I mean, this is part of your
Right.
health, an important part of your health. And so this is embedded in your healthcare for your life because metabolic dysfunction is part of your genetic makeup. So of course you need to be constantly looking at that metabolic function and working on making sure that you're strengthening it and not doing anything that's like weakening it or giving it a chance to cause a problem. For example, I remember, Andrea, we made a lot of progress early on, and then remember you got sick.
Oh, yeah.
And I was very nervous because I thought all that diet stuff was going to come back because you could not
Right.
eat. You could not eat.
No.
You were so sick and you had some terrible, I don't know what it
Yeah.
was. So that was when, after that, all the progress stopped for like a year and a
Yeah,
half. or
I had like a year setback.
A year
Because not
set-
only could
yeah,
I had
right.
a problem, and I had medication that some
triggered.
steroids that
Yes.
were making it worse.
Yeah.
So I had a little setback for a while.
Yeah.
But I got back on track. Everything worked back, and
That's what I mean. You carry your metabolic vulnerabilities with you throughout your
Right.
life. And so having your metabolism be part of your regular healthcare forever, that's normal.
Right.
It's not like, when am I going to be done with this? It's not that
No,
way. We
it's
shouldn't
never
look at it
over.
like that. Right. We shouldn't
never
really look at it
over.
that way. I mean, you can say, well, now I'm not necessarily having to take blood pressure medicine, or I don't necessarily need to
Yeah.
I don't have fatty liver, or I don't have, things like
Right.
that are big milestones. But in terms of, we always separate like our weight as if it's this thing, and then that's not connected to
It is all.
metabolic.
You're right. It is all connected. I
yeah.
somehow sometimes I think of it as unconnected, but you're right. It is all connected.
So Dr. Cooper, when I first came to see you, I think every marker was in the wrong column. My blood pressure was bad. I had high cholesterol. I had fatty liver. I had elevated blood sugar. I was pre-diabetic, and I didn't look unhealthy. I mean, I was.
No, we thought you were really pretty healthy and probably just had to lose 5 pounds.
Yeah, I was probably. I think I was 30 or 40 pounds heavier than I am right now. But for me, it was all genetic. I had a grandfather who was diabetic, and on my dad's side, pot-bellied men were sort of the norm all the way back. And what I think is so amazing, Dr. Cooper, about what you do is that was what, 12 years ago, 11, 12 years ago when we first started this. And now we're having discussions that sound something like, oh, your cholesterol is a little bit too low.
Yes.
And, oh, your blood pressure might be a little too low. And what I think is, and I'm really grateful for this, Dr. Cooper, because if I had not met you and if these things had been left untreated, it was going to lead to something catastrophic at some point, whether it was full-blown diabetes, whether it was a heart attack, whether it was
Stroke.
Right.
Did you know your grandfather had diabetes, or was it just like left unchecked?
Well, in that era, he was born
That's what I mean.
Just around 1900. I mean, he was in that era where, he had angina, chest pains, and he would just whip out the bottle of nitroglycerin pills and dissolve a pill under his tongue. It's like, instead of going to get his heart surgery, like to unblock his arteries, they would just give you a nitro pill and the chest pain would go away. And he eventually died of a massive heart attack. But it was just a different era, I think, back then. We just didn't know, what we do now.
Right.
So,
Right.
Dr. Cooper, as you look at the transition and the transformation that I've experienced over the years, I'm just super grateful. I used to inject testosterone, and now my body's creating enough of that. And there have just been so many milestones where we're getting to this optimal stage that I just couldn't be happier about.
It's true. I looked back at that original and I saw, wow, I didn't remember that your blood pressure was really high and you weren't on blood pressure medicine or anything. And we were trying to get you onto an exercise nutrition program because it was kind of part of what we were doing. But then we were thinking, wow, this blood pressure is high. We've got to get that under control. And then the pre-diabetes that you weren't aware of was there. And the cholesterol levels, the triglycerides were really high. And so it's all these things that you just didn't know. And that's why these things can be very silent. You knew that you weren't feeling your best. I think that you were thinking your energy was kind of low and your waist was kind of getting bigger and you weren't sure what was really going on. You did have a really hard job at the time where your sleep was super disrupted, which also impacts it. And then later you found that you had sleep apnea too, which impacts it. But
piling on.
Piling on the problems.
But I'll tell you, that sleep apnea was a massive game changer, getting on the CPAP machine and just getting that. I was stopping breathing a couple of times a minute during the night.
Yeah.
And it was like, how do you get a good night rest if you're stopping breathing and your body's freaking out?
It's true. And I think people should keep that in mind. If they are diagnosed with like high blood pressure and they've got insulin resistance or prediabetes, increasing body weight, is there sleep apnea there? Because it can feed into those problems. And maybe it's not the only cause, but it definitely can exacerbate metabolic dysfunction and lead you towards those things even further. So I think treating sleep apnea is really important if it's there.
Diagnosing sleep apnea now is so easy. You just go in and you put this little device on your chest at night at home. You go home and sleep one night, and then you return the device to the doctor. They're going to be testing me now because I may not need the CPAP anymore because I've lost a lot of weight, and so that may not be as significant an issue as it was before. But if I could give our listeners one bit of advice, it would be really pay close attention to your family history, because everyone in my family was on blood pressure meds except me. And I should have seen that as a big red flag, because everybody, mom, dad, brothers, everybody was on blood pressure meds. And so pay really close attention. The genetics are such a strong driver of all this stuff that if there's a problem in your family for everybody else, there might be a pretty good chance that it's going to happen to you too.
Yeah,
That's
there might be
true.
a reason that why when they ask you, when you see a new doctor and they ask you to fill out, does anyone in your family have a heart issue?
Yeah.
Maybe there's a reason.
It's true.
Yeah, but Dr. Cooper, just to put a bow on that idea, the reason that we're doing all this is not so that we look thin or we look healthy. The reason that we're doing all this is really to just get us to optimal health.
Yes.
And to prevent catastrophic health events, because just blood pressure alone, take everything else off the table. If you just had high blood pressure, it's not going to end well at some point for you.
And when you mix together the high blood pressure and the cholesterol particle, LDL particle elevations and plaque formation and things like that, that's really what mixes together to cause the most common types of strokes, ischemic strokes. And these things, as I say, they're kind of silent. So every once in a while, we'll run into patients where they're very kind of resistant to this. I mean, you were very willing and eager to try to correct these things, but some people think, well, I don't really want to treat that, or I don't feel anything. Why should I? There's nothing wrong. I try to explain these are silent killers. It's not that you suddenly have symptoms that you have high blood pressure. Most people don't even have symptoms, maybe a headache, but usually there's not a lot of symptoms with high blood pressure. And same thing, if you have elevated LDL cholesterol particles, you may not have symptoms, so you have a heart attack or a stroke. These are things that, again, it falls under that preventive medicine perspective. And that's what both of you did really when you came in. And Mark, your labs look completely different than when you started. Yeah. And you're not really on a lot of medication to control it now. Mm-hmm. So I think it's good. It shows that the body wants to be its best. And a lot of things interfere with that function that are environmental, the endocrine disruptors, the sleep apnea, the bad long hours, work hours, and lack of sleep, eating on the run and not getting the nutritious food and not being able to get regular activity. Just so many things feed into it. But it's, once you can take the whole thing holistically and do your best in all these different areas, including treat these things medically, you'll see that a lot of it's reversible to some extent.
I know a lot of people who sort of wear this as a badge of honor. They're like, oh, I don't take any meds. It's like, and they resist taking something like a blood pressure med because they don't want to be seen as someone who needs high blood pressure medication. But I'm the guy that's the complete opposite. You tell me, let's try this. And I'm like, yes. And I'll tell you, I am religious about my medications. I never miss a dose of anything. Good. And just because I want to give my body a fighting chance. And this stuff is only going to work with consistency. So,
right. It's true. There's
throw
a lot
the badge of honor out the window.
It is. It's so much stigma, especially around diabetes, obesity, as you said, hypertension, these things that have this image or stereotype that lifestyle will correct it. Or if you only had a healthy lifestyle, that's just not true. That's not true at all because, again, as you said, the genetics is just huge in terms of triggering our vulnerability. And then the environmental impacts that we can't avoid, they increase that. And there's a lot of things we cannot avoid with our environmental exposures. But even if we could, because of the genetics and all of that, you could have the most impeccable lifestyle and still need blood pressure medicine, medication for diabetes, medication for your cholesterol, anti-obesity type medication, like all of that stuff.
I have beautiful cases for my medicine. I honor my medicine with a beautiful case. I have no problem. I mean, it's like, why would you be, I don't understand it. I'm like, if you need medicine, take medicine.
Well, I mean, you want to make sure it's safe.
Right.
And
it's like if you have a cut, put a Band-Aid on it.
Right. I mean, you have a relationship with your primary care doc. That's why you have that. You want to talk to them about all your concerns, and they're valid. If you've got concerns about a medication or questions about it, that is totally valid. You should for sure have that discussion with your primary care doc. Sometimes, we are open to hearing all kinds of things from our patients, and sometimes the patients find stuff that I wasn't aware of, and then I can research that and find out and get back to them on it.
But I also think you can over-Google.
True, you could. But it's still worth asking your doc because just relying on Google.
I don't know. I just think if you need something and medicine will make your life better life through chemistry, I think that there's nothing to be ashamed of.
No.
It's like if you're going to be living,
Be healthy.
live a great life. If you're not going to be living, well, don't live. But if you're going to be living, live a great life.
And I think we should get Dr. Cooper a vanity plate for her car that says the Unglitcher.
Yeah. She is the unglitcher.
The Unglitcher, like you mentioned before
I just
we
wanted to
wrap
say
up.
one thing. I mean, I was going to say most of the unglitching just comes from the person doing this, where you guys, eating regularly. That's like the key to it, like to unglitch those diet-induced diet damage type of stuff. And so just eating regularly, consistently, taking the meds consistently, working on the sleep, and then leave it to the healthcare provider to try to figure out, okay, what do we need to do medically from our end to support this? So it's a team effort.
So I guess we could say that treating metabolic dysfunction is not rocket science, but it is. It is science.
It is science. It is science. And I'm not that good at science, but I'm a team player.
Yeah. And, we've learned that the labs are our friend. So
Yes.
integral part of the process. This has been such a fun conversation. Thanks, you two, for another edition of Fat Science.
No diets, no agendas, just science that makes you feel better.
I'm Mark Wright. Thanks for listening to Fat Science with Dr. Emily Cooper. New episodes drop every Monday. If you've enjoyed the conversation, subscribe, rate, and review this podcast. This production is for informational purposes only and is not intended to replace professional medical advice. Join us next week for another episode dedicated to the science of why we get fat. No diets, no agendas, just science that makes you feel better.